end of the session. So once again, I welcome you all, and over to you, sir.
Good evening to all of you. I thought I will share some practical tips. Please, I request all to mute except when talking. Practical tips on managing seizures. Because seizures need proper clinical evaluation. Anyway, right now I may not be seeing many patients with seizures when they are in seizure, but still the approach is same. So I will share with you my experience on how I would have evaluated a patient who is brought with seizure wherever we are working. I'll start sharing the screen now. Please mute. Please mute all. Please mute. Please mute. Can you see the screen? Hello.
Yes, sir. Yes, sir. We can see.
It is purely a clinical approach, not much of theoretical aspects regarding seizures. You may see a patient who is brought with a history of seizure, or they might give a history as fainting or giddiness. Always remember to interview the eyewitness to decide whether it is a seizure disorder or not. And always take care to differentiate seizures from syncope, vertigo, transient ischemic attacks. Not all transient ischemic attacks, it is the vertebrobasilar insufficiency type of TIA. And remember to differentiate also from pseudo seizures. These four problems have to be differentiated before you make a diagnosis of seizure disorder. And that needs careful interview of the eyewitness. It's not possible to diagnose it by interviewing the patient alone or doing investigations. The most important the investigation or evaluation is to interview the eyewitness who had witnessed the event. Syncope, you can easily differentiate from seizures because it usually occurs in the standing posture or walking. Rare to get syncope when the patient is lying down, that is cardiac causes, extremely rare. Most of them are occurring either in the standing posture or when the person is walking. Duration of loss of consciousness is almost nil in syncope because it's only for a fraction of a second. Unless you forcefully keep the person upright, the person with syncope will never lose consciousness. Please mute all. Voluntarily, you can mute all of them from the side of the. So the in syncope, practically you will never get loss of consciousness because the moment patients feel that blackout, patient will lie down, and immediately the consciousness is regained. So practically you will never see a period of loss of consciousness in syncope. That is why some people call it as pre-syncope. So if there is loss of consciousness for a long period, it is not a syncope. Either it is transient ischemic attack or seizure. Unless by chance somebody is forcefully keeping that person sitting upright, there will not be any loss of consciousness. And there will not be any involuntary movement. But a transient jerky movement might be seen sometimes when you watch the patient developing a syncope. Other than that, there won't be any syncopal involuntary movements. And you will definitely find a precipitating cause for syncope, like the posture or underlying disorder like hypotension, volume loss. Definitely there will be something or a cardiac cause you will be able to find out. As compared to that, a seizure can occur in any posture. And you will usually get a history of prolonged loss of consciousness, especially in the generalized tonic-clonic seizures. The loss of consciousness is a little more prolonged, and other features of seizure will be there, like the involuntary movement, tonic posture followed by the clonic posture, followed by the conscious state. That sequences of events are very clear. And again, you might get a precipitating cause for seizures that we will discuss as we go on. And during the seizure, the patient is likely to injure somewhere, hitting the head or biting the tongue, or falling into some accident-prone areas. These are unusual in syncope unless by chance the patient is standing on a narrow path where there's nothing to hold on. Otherwise, the patient will never fall and injure. Incontinence of urine also is very common in seizure disorders. These will never occur in syncope. As compared to that, vertebrobasilar insufficiency will not have any involuntary movements, but the patient will be developing loss of consciousness, which is longer. So actually, it is not difficult to differentiate between syncope, seizure, and transient ischemic attack of the vertebrobasilar insufficiency type. But the most important thing to differentiate is pseudo seizure and genuine seizure. Pseudo seizures will occur. The person who develops it will make sure that it happens in the presence of somebody to witness it. So it will never occur when the person is alone genuinely, or at least the person will make sure that somebody will immediately come and see it. So that situation will be there. And the pattern is very bizarre. You will never see the typical pattern of genuine seizure in pseudo seizure. One limb may be upright, another may be lower down, and the movements are never symmetrical. And you will never get postictal phenomena. Please mute. You will never get postictal phenomena in pseudo seizures. The postictal phenomena are very classical, and they will find only in genuine seizures. And they will never injure in pseudo seizure, and it will never occur during sleep, unless by chance, again, there is somebody to witness it. It might. Right? What is happening? Please mute all of them. It will never occur in sleep in pseudo seizures, and there will not be an incontinence of urine. And these are not enough to diagnose a pseudo seizure. There will be a positive mental conflict in the patient's mind. You can find out a problem in the social life, marital life, or financial conflict. Something will be there if you elicit it. That has to be definitely elicited to diagnose pseudo seizure. So in other words, by developing a pseudo seizure, there will be a secondary gain. And never suspect pseudo seizure in an elderly person. As compared to that, a genuine seizure can occur anytime, anywhere. The typical pattern can be observed by eyewitness, or sometimes we can observe when the patient is brought in seizure. And that definitely they have some kind of a postictal phenomena. The postictal phenomena can be confusion, headache, vomiting, or prolonged altered sensorium. And the patient might injure. It can occur during sleep. Incontinence can occur. And there is no secondary gain or a mental conflict, and any age can be having genuine seizure. So it is not difficult to differentiate pseudo seizure or syncope or vertigo. When you, in fact, what is seizure? Seizure refers only to the electrical discharge. The paroxysmal, abnormal, excessive electrical discharge in brain is the definition of seizure. But the corresponding manifestation is what we refer to when we say seizure. Even the involuntary movements, we might call it a seizure, but genuinely the seizure means the electrical discharge. That's why people more often depend on EEG to diagnose seizure. That we'll discuss as we go to investigations. As compared to that, convulsion refers only to the motor manifestation. This can happen only when the seizure discharge is in the motor cortex. The abnormal electrical discharge, if it is in the motor cortex, only will have convulsion. By chance, the abnormal electrical discharge happens in the sensory area cortex, you will find abnormal sensory involvement. If it is in the occipital cortex, you will find visual hallucinations. If it is in the smell area, you will find abnormal smell in the as a manifestation of seizure. So convulsion is not seizure, but convulsion can be due to a seizure. Convulsion only refers to the motor manifestation of a seizure discharge. But convulsion is due to seizure. Epilepsy refers to when a person gets recurrent seizures due to a chronic underlying process, or two or more unprovoked seizures without a definite identifiable correctable disorder. You will not find a definite completely reversible problem, and the problem keeps on recurring. Then only call it as epilepsy. So the epilepsy is definitely an entirely different problem. As generalist doctors, we are more worried about seizures due to other problems. Epilepsy, when it comes to epilepsy, it becomes a problem more often dealt with by neurologists. But more often, the seizure is a medical problem. Anyone may come across it, and we must be thorough with the evaluation. Suppose you are witnessing a person brought in seizure. Brought in seizure may be having involuntary movements, or immediately after that, patient may be in post-ictal coma. Always keep the patient in lateral position. Left lateral is ideal. Protect the airway. Check the vitals. Introduce an IV cannula. Immediately take blood sample for sugar, electrolytes, urea, and a hemogram. These are going to give vital information regarding the precipitating factors and the cause of seizure. And then give medications to control the seizure, even when the patient is in the post-ictal coma, because it might occur anytime. The medications to control a seizure when the patient is brought in seizure is, most importantly, it is diazepam, given slowly. The dose you can cross-check, and it can be repeated every 10 minutes, but a maximum dose should not go above 40 milligram. Instead, you can, these days people prefer lorazepam, given over 1 to 2 minutes, repeat after every 5 minutes. But both are used till the anticonvulsant the effect of phenytoin or phosphenytoin is established. This is a F. This is not, these drugs are only for immediate control. Simultaneously, we'll be starting on phenytoin or phosphenytoin, and the effect of that will be established after some time only. And if you give a loading dose, the effect can be established immediately. But once the effect of other anticonvulsant drugs take place, then you can, then you will not repeat lorazepam or diazepam. The loading dose of phenytoin sodium given is 15 milligram per kilogram, slow IV. This is FOS, phosphenytoin. And immediately after giving diazepam and the seizure is controlled, if there is no more seizure, you can start to the maintenance dose also. That is 100 milligram 8 hourly of phenytoin sodium. Loading dose only when you think that seizures are likely to recur. That's when you want immediate enough CSF barrier it has to cross, and enough concentration in the brain, CSF fluid. If you want to achieve, it has to be given as a loading dose. Otherwise, once the seizures are controlled, start with the maintenance dose. Don't be happy with the diazepam alone. If you're sure of the genuine seizure, keep the patient in a lateral position, preferably left lateral. Clear the throat and oral cavity of secretions and other foreign bodies. The foreign bodies can be food items or sometimes dentures or anything. Prevent aspiration of secretions and foreign bodies or food items during a seizure. That's very important to prevent aspiration pneumonia. And can be done in between seizure or after controlling the seizure. Along with that, if the patient is brought in seizures, giving 25% dextrose is an important measure, because very often hypoglycemia is a precipitating factor. If you're sure it is not hypoglycemia, then only you can avoid it. Otherwise, giving 25% dextrose is very good in a patient brought in seizures. But if you're sure it is a hyperglycemic state, don't give it. Another medicine which can be thought of is dexamethasone, because sometimes the brain edema may be cause for recurrence of seizure. So giving 1 dose of dexamethasone might reduce the brain edema, and it might be helpful sometimes. And if you're sure there is raised intracranial tension, give mannitol once. And if you think there is dehydration, hyponatremia as the precipitating factor, instead of or at least after giving dextrose, start on normal saline. And another drug, another medicines that can be controlling seizures can be calcium gluconate or magnesium administration. When there is failure to get IV access, as in children, rectal administration of diazepam can be resorted to. And while if the patient is brought in seizures and you get an opportunity to observe the seizure, watch for the pattern of seizure. Is it a focal seizure involving only one limb or just stitching of the face alone or turning one side, limb is moving on one side only or lower limb or upper limb alone? Or is it a generalized seizure? Generalized seizure only means the patient loses consciousness. In fact, when all four limbs are involved, it is always a generalized seizure. But in fact, the term generalized refers to loss of consciousness. Or is it a focal seizure to begin with the secondary generalization and loss of consciousness and involvement of all four limbs? Or is it a status? Status epilepticus refers to repeated seizures in between patient fails to regain fully conscious state. That's all what it means by status epilepticus. Or sometimes it may be a focal status. That means one limb alone is moving continuously without any break. And that becomes a focal status. Or also observe the pattern of seizure to decide whether it is pseudo seizure. Pseudo seizure will now have a specific pattern. And as I said before, you can look at other features to support a pseudo seizure. Sometimes it may be a CVA with a seizure, in which case you may find a neurological deficit and involuntary movement on one side. And after identifying that it is a genuine seizure, then we need to look into the causes of seizures. Many of them are idiopathic seizures. Idiopathic seizure refers to no obvious structural disorders, but the patient keeps on getting repeated seizures. Or people with idiopathic seizures have a seizurogenic focus in the brain, anywhere in the brain. These are low threshold areas, and it can start fire discharge, a paroxysmal electrical discharge whenever something happens, like sleep deprivation, electrolyte imbalance, hypoxia, hypoglycemia. Any of them can precipitate idiopathic seizures in people with a low threshold seizurogenic focus in the brain. This seizurogenic focus itself may be due to some birth injuries or some injuries in the past or a scar. So anyway, these are called idiopathic seizures because there is a tendency to recur and you don't find any obvious cause on evaluation. And that is why you call it as an idiopathic seizure. Actually, idiopathic seizure does not mean that there is no cause. There is always a cause, but the majority of the group comes under the idiopathic seizure group. But even if you think of an idiopathic seizure, there will be secondary causes that would have precipitated seizure even in those persons with a proneness for the so-called idiopathic seizure. Idiopathic itself is not truly idiopathic. The secondary causes that we need to look for are hypoglycemia, metabolic causes like hypoglycemia. It may be hyperglycemia sometimes, hypocalcemia, hyponatremia, hypomagnesemia, or rarely porphyria. And an acquired porphyria you may get in lead poisoning. The secondary causes can sometimes be vascular. Most important vascular cause for seizure is a cerebral vein thrombosis. This is notorious to present with headache and seizure as the first manifestation sometimes, but it can have various other manifestations. So if you have a CVA with the features of raised integral, CVA means sudden onset neurological deficit, headache and seizure, always consider cerebral vein thrombosis. Another vascular cause is embolism, because embolism only has the propensity for the blood clot to dislodge and go to the cortex. So that's why the patients with embolism can also come with seizures sometimes. But a patient who is prone for seizures with a seizurogenic focus or low threshold focus might throw a seizure due to any ischemia due to any mechanism. The ischemia may be due to sometimes a transient ischemic attack involving any of the vascular territories, or it may be even migraine. So even syncope can trigger seizure in some of these individuals. So vascular events may be a trigger even for the so-called idiopathic seizures. Now forget malignant hypertension. These may manifest, come with generalized tonic-clonic seizures. And if you forget to look at the blood pressure and fundus changes, you will miss it. And sometimes patients with the seizures may have a reactive hypertension, and high blood pressure alone is not enough. The fundus changes are also equally important to diagnose malignant hypertension as the cause for a secondary seizure. Very rarely, sometimes at least, you may find a meningioma as a cause for a seizure disorder or an AV malformation. Rarely, sometimes other benign structural abnormalities of the brain can be presenting with repeated seizures. But always consider CNS infections, especially when the patient has got fever and other recent onset seizures, of which encephalitis is the commonest. Meningitis can have meningoencephalitis. Sometimes the brain abscess, if it is situated near to the cortex, can have seizures sometimes. Alcohol-related is a very important cause of seizure. So it is very meticulously you have to ask about alcohol intake, because alcoholics are prone for hypoglycemia, and that is why they often get seizures. Sleep deprivation is another important cause for seizure in anyone. Prolonged sleep deprivation can produce seizure in persons with no history of past history of seizure, but they have a low threshold focus. That is why they get it. And idiopathic seizures are always, they are prone for getting recurrence whenever they have sleep deprivation. So whenever you have an idiopathic seizure disorder, any of the causes which we mentioned before could be a precipitating cause of seizure in a person with previous idiopathic seizures. Always look for structural disorders of the brain, and which may not be obvious always. It could be the result of a previous ischemia or an infarction or injury in the past. These patients can also come with seizures later on. And if that history is missing, you may brand it as an idiopathic seizure disorder. And in fact, many patients with seizures have multiple problems. This is the most important point to keep in mind when we are evaluating patients with seizures. The patient could be having a scar, could be having an ischemia, could be having a metabolic problem, and the metabolic problem itself could be multiple, and the same patient could be having sleep deprivation. So the success of management lies in identifying all the contributory factors for a seizure precipitation or seizure manifestation. So these are the steps that we usually adopt in managing patients with seizures, having identified it as a genuine seizure, having ruled out pseudo seizures, transient ischemic attack, and the syncope. You have a patient with seizures. So the step one is to control the seizure, which we have mentioned in the beginning. Then a quick preliminary examination has to be done. Even as you are controlling the seizures with the medicines, you will be, along with that, you will be checking the important vital signs and important general examination findings, and some details regarding the cause you would have arrived at by that time. And after that, once the seizure is controlled, the most important step is a detailed evaluation to find out all the contributory factors and the exact cause for the seizure. All these three steps have to be carried out. For control of seizure, as I mentioned before, introduce an IV cannula into an upper limb vein and take blood sample for urea, sugar, and electrolytes. Using the same cannula, you can give 50 ml of 25% dextrose, and after that, you then start on 5% dextrose. The reason for starting dextrose 25% and starting 5% dextrose is hypoglycemia may be the cause of seizure, and repeated seizures of any etiology lead to an increased metabolic activity of the brain, and there is neuroglycopenia. This can aggravate seizure further. That is why, unless you are sure there is hyperglycemia, do not hesitate to give dextrose in anyone who is brought in seizure, because many of time they have hypoglycemia or a repeated seizures would have produced a neuroglycopenia, and seizure begets seizure is the point that we have to keep in mind. That is why giving dextrose always helps. But avoid dextrose if the patient is by chance likely to have hyperglycemia, which will be obvious from the history. In that situation, if you think it is an uncontrolled diabetic having hyperglycemia, diabetic ketoacidosis having seizures, start on normal saline only. Do not give dextrose there. Diazepam, as I mentioned before, will be started given slowly. Maximum dose 0.3 milligram per kilogram. 5 to 10 milligram IV start very slowly may arrest the seizure, but and maybe repeated every 10 minutes if the seizures are not controlled, or till a maximum dose of 40 milligram is good. But do not go beyond that dose. Or as I mentioned, lorazepam given over 1 to 2 minutes, repeated every 5 minutes, and it may be repeated as well as till the anticonvulsant effect of other drugs like phenytoin establishes. So you'll be simultaneously giving phenytoin or phosphonatoin, and if once its effect is established, you can stop giving diazepam. But while giving diazepam or lorazepam, watch for respiratory arrest, and if one should be prepared for ventilating the patient. Ambubag ventilation must be ready there if you are giving large amounts of loading dose of diazepam. But up to 10-20 milligram may not be much of a problem, but still one must be looking for respiratory arrest. If the seizures are controlled with the diazepam, simultaneously start on phenytoin sodium, 100 milligram 8 hourly. But if the seizures are occurring, as in a status epilepticus, or if you think they are likely to recur, then you give a loading dose of phenytoin. That is 500 to 1000 milligram as a direct intravenous dose. And it is given as 15 to 20 milligram per kilogram, given as a slow IV at the rate of 50 milligram per minute, followed by a maintenance dose of 100 milligram 8 hourly. This loading dose is given only when you want to establish a quick control of seizure, or if you think that it is status epilepticus. If the seizure is already controlled with the diazepam and you don't think it is likely to recur, then you start with the maintenance dose of 100 milligram 8 hourly. If necessary, for ease of slow administration, the phenytoin sodium may be diluted with equal volume of normal saline, but do not use dextrose to dilute phenytoin sodium. And while giving phenytoin sodium loading dose or bolus administration, always palpate the pulse, or if you have facility, watch the ECG on the monitor. Otherwise, keep palpating the pulse as you infuse the phenytoin sodium. Loading dose only if the patient was not on phenytoin sodium before. By chance the patient was on phenytoin sodium, do not give loading dose of phenytoin sodium. Alternatively, phosphonatoin can be given at 15 to 20 milligram per kilogram body weight at a maximum rate of 150 milligram per minute, followed by maintenance dose of 150 milligram IV 8 hourly. This is preferred because there is no risk of thrombophlebitis with the phosphonatoin. If the patient is still having seizure, you may repeat phenytoin or consider sodium valproate. Still not controlled, you may think of phenobarbital infusion, but I have no personal experience of using this. And after retirement, I have not seen any patient to control seizure when it has come. So I cannot tell some practical points at this point. But anyway, adequate ventilatory facilities should be ensured before repeating phenobarbital administration. In case the seizures continue to occur, the patient would be admitted to the ICU, and seizures should be controlled by anesthetic agents and ventilatory support. That's a last resort. At this point, anyway, generalist doctors will not be involved. The patient will be shifted to the ICU with ventilatory support. There are some other steps in controlling patients with the status epilepticus. Because in most patients with the status epilepticus may have thiamine deficiency, and it can lead to Wernicke's encephalopathy. Especially it is so common in chronic alcoholics with the status epilepticus, or even those with the borderline undernutrition. Wernicke's encephalopathy can occur after status epilepticus. So it's a good practice to give injection thiamine 100 milligram IM start in all patients with the status epilepticus. And also, do not forget to correct other deficiencies. Though their effect may not be indirect, they will also contribute to control of seizures or prevention of recurrence. Like the patient is having B12 deficiency, folic acid deficiency, vitamin D deficiency, hyponatremia, pyridoxine deficiency. Patients on INH may be prone for this particular problem, and hypocalcemia and magnesium deficiencies. All this can be corrected by proper diet and vitamin supplements, and if necessary, you may give calcium gluconate or magnesium intravenously. If there is no contraindications for giving dexamethasone in status epilepticus, always give dexamethasone 4 milligram IV start, because this will reduce the cerebral edema. which might act as a vicious cycle precipitating further seizure discharges. This is what I mentioned before. Seizure begets seizure. One seizure means there will be a residual cerebral edema, and that is a trigger for another seizure. So this cerebral edema, if you control, may prevent recurrence of a seizure. That's why the dexamethasone is given in some patients with the status epilepticus. I mean, even otherwise, an occasional patient with seizure could be having hypoglycemia and hypoadelism. That patient also will benefit by using dexamethasone in seizures. Sometimes when the patient is brought, there may not be any seizure, but the patient may be in post-ictal coma. So as I mentioned before, you have to take care of putting the patient in left lateral position, protecting the airway, always check the vitals, establish IV lines, and take samples in that patient also. And always give the treatment for maintenance dose of phenytoin sodium has to be started immediately. And by chance you think that seizures are likely to recur, even in that patient, you have to give a loading dose. Or if by chance seizure recurs when the patient is under observation, you have to give a loading dose of phenytoin sodium. Mannitol may be used to control cerebral edema in some patients with seizures, which are intractable cerebral edema sometimes. Dexamethasone may not be enough. And if these are given when the patient has obvious features of cerebral edema, this can happen in patients with hepatic coma or seizures with CNS infections like encephalitis or meningoencephalitis. But normal saline may be started if the patient is likely to have hyponatremia, which you can assess from history of vomiting, diarrhea, or any signs of dehydration in a patient with seizure. Or if there are any history of diarrhea, vomiting prior to seizure, always start on normal saline because hyponatremia may be the cause for seizure. Or if you think hyponatremia is the cause because of some reason like the patient on thiazide diuretics, you always start on normal saline as the first IV fluid. If the patient is a non-diabetic and has a historical or biochemical features to suggest uncontrolled diabetes, again, normal saline is the IV fluid of choice. Do not give dextrose by plan in this patient. Intravenous calcium and magnesium may have a role in selected cases of seizures when the patient is likely to have hypocalcemia, which again you can check by looking for Chvostek sign, or if they are known to be predisposed to malabsorption or vitamin D deficiency due to any cause. So one should explore the possibility of hypomagnesemia and vitamin D deficiency, even B12 folic acid deficiency by a detailed dietary history as you go on. In case there is any difficulty in getting intravenous access, rectal administration of diazepam can be given in children at least. During this, when you are controlling seizure, you will be doing a preliminary examination, which I have given as step 2, and it has to be done simultaneously during the initial management to control the seizures. You will be checking pulse, blood pressure, temperature, and respiratory rate. If there is tachycardia and shock, septicemia due to any cause may be the reason for seizure. Bradycardia may be due to raised intracranial tension, may be due to an intracranial space occupying lesion. It may be an cerebellar thrombosis, but occasionally a complete heart block may be the reason. In that case, Stokes-Adams attacks could have the precipitated seizure in that patient. If you find an irregular pulse, it could be an atrial fibrillation with embolic stroke. Embolisms are known for precipitating seizures. And when you get an opportunity, look at the fundus for evidence of papillary edema, hypertensive or diabetic changes, because this will give important clues regarding the cause of seizures. Other relevant examinations, if any, should be done as quickly as possible as you are controlling seizures, but detailed examination only after controlling seizure. But if the patient is throwing seizure, control the seizures without wasting time. Rest of the evaluation can be done after controlling the seizures. So that is up to step 2 will be up to controlling seizure and preliminary examination. And the step 3 of evaluation of seizure is to arrive at the etiological diagnosis. That means all the contributory factors for the seizure, including precipitating factors, underlying organic problems. If there was an idiopathic seizure, also the same thing has to be done. And it is got by history, physical examination, and some investigations. A detailed history and physical examination, I will give some guidelines to follow in any patient with a seizure disorder. Always remember, in those patients who come with history of giddiness, fainting, always verify by a good history, whether it is seizure, vertigo, TIA, or just a syncope. This has to be done first before you think of evaluating as a seizure. In suspect, which I have already mentioned, this is possible by interviewing the eyewitness. In suspected seizures, when the patient's higher mental functions are impaired, never forget to interview the eyewitness. That need not be the person who is staying with the patient. It may be anyone who has witnessed the patient having seizure. It may be somebody who has seen in the office or workplace or on the road. You can contact that person or bring that person to get a first-hand information of what happened during that event. That will be the most important investigation. So the most important investigation to diagnose seizures or to differentiate it from other conditions like TIA, pseudo seizure and all is interacting with the eyewitness. And get all the details, even if it is, once you're confirmed it is seizure, get all the details like duration of the seizure. Was it a long-term, long history of seizure with recurrent episodes, or is it a first seizure? And then also find out the correct description of the pattern from eyewitness and the patient. Patient can give details only up to the point of losing consciousness. Rest of it has to be from the eyewitness, not from the immediate relative. The eyewitness can be anyone. And always look for precipitating factors. Most importantly, sleep deprivation, alcohol, fever, and electrolyte imbalance. These are the common precipitating factors in all patients with all kinds of seizures. And always ask about past history and family history of seizures. That suggests that it is an idiopathic seizure disorder. Even in patients with idiopathic seizure disorder, the precipitating factors are usually the same. A family history of seizure can suggest idiopathic epilepsy, but not always. That's the point we have to keep in mind. Details regarding associated illness has to be elicited, because even if the patient has an obvious cause, if the patient is hypertension, the malignant hypertension may be there underlying. If the person is diabetic, hyperglycemia or hypoglycemia may be responsible. If the patient has RHD or ischemic heart disease, an embolism may be underlying, or a ischemic event may be underlying precipitating factor. And always study the lifestyle habits and addictions of the patient, including alcohol intake. Always get a detailed diet history to explore the possibility of B12, folic acid, and vitamin D deficiency in a patient presenting with seizures. Details of alcohol consumption has to be elicited always, because seizures can occur after alcohol intoxication or after alcohol withdrawal also. In alcoholics, especially chronic alcoholics, their glycogen stores are depleted. So the first protection against hypoglycemia is a glycogen store in the liver. In our chronic alcoholics, they may not be having much of glycogen because they always take only alcohol and very little of other food items. So glycogen stores may be depleted. And in addition to that, alcohol has got a direct interference on gluconeogenesis by the liver. So alcoholics are prone for hypoglycemia during alcohol intoxication or on alcohol withdrawal. So the hypoglycemia is the commonest cause for seizure discharge in a patient who is an alcoholic, even if it is acute alcoholics intoxication. Chronic alcoholics can have seizures even after withdrawal from alcohol. And other addictions like ganja and other addictions has to be asked for in patients who are brought with seizures. If there is a fever, and detailed history includes presence of fever prior to the onset of seizure or during seizure, or when the patient is brought, they may not have noticed fever. If you notice fever, the problems are entirely different. Or if there is still diarrhea and vomiting prior to seizure, it might suggest hyponatremia, or if there was significant dehydration, think of cerebral thrombosis as a cause for the seizure disorder. Headache prior to seizure can be due to cerebral thrombosis or a migraine sometimes. So always ask about headache before the onset of seizure. This can indicate either cerebral thrombosis or a migraine. Symptoms of raised intracranial tension prior to seizure has to be looked at. This can suggest intracranial space occupying lesion or cerebral thrombosis. Use of diuretics like thiazide diuretics should always be encouraged. Hyponatremia may be the trigger. Use of hypoglycemic agents like sulfonylureas, insulin, always ask about. And the possibility of hypoglycemia should be explored if the person is on hypoglycemic agents. And if a person is on anticonvulsants, stopping the drug, changing the drug, or sometimes drug overdosage may be the cause for a recurrence of seizure. Presence of fever in a patient with seizure would make one think of the following causes like encephalitis, meningitis, brain abscess, cerebral malaria, septicemia, or it may be a person who had been having idiopathic seizure or a seizure predisposition with a low threshold seizurogenic focus in the brain. And whenever they get fever, they might throw a seizure. So fever would have been acting as just a trigger for seizure in such individuals. You may not find anything on investigation. So, or it may be direct involvement of the brain by any of the other causes which I mentioned. In the detailed history, duration of seizure, is it a first episode or was he non-epileptic, has to be always clearly elicited. And how many seizures he had in the past? Has he regained consciousness in between? If he has not regained consciousness in between, it's a status epilepticus. When was the last seizure is very important. Who was the eyewitness is important. You have to get that person, interview the eyewitness regarding the details of the attack. That alone can differentiate it from other differential diagnosis issues. And this is the most important investigation. I will always repeat that interviewing the eyewitness is the most important investigation to diagnose it as a seizure disorder. And observe the pattern of seizure. Either observe the pattern directly or by interviewing the eyewitness to find out the pattern. You will not get the pattern from the patient. Patient can never give the pattern of the seizure. It has to be by observing when the patient is having seizure or interviewing the eyewitness. Sometimes this step will help us to know that it was not seizure at all. It may be a pseudo seizure, or sometimes it is TIA or syncope. So always take pains to interview the eyewitness. You can easily differentiate rather than depending on EEG to diagnose a seizure. So if the patient has seizures while under observation, or whenever possible, observe the pattern or get the information from an eyewitness. Is it a focal seizure that is confined to one limb or another portion of the body without losing consciousness? This focal seizure need not be always with the motor movement. It can be sometimes abnormal smell of sudden onset, abnormal sensory involvement of sudden onset, abnormal hallucination, visual hallucination of sudden onset, or abnormal auditory hallucination of sudden onset, or abnormal behavior of sudden onset. So is it a focal seizure or not? That has to be found out. But usually it is a convulsive movement that we are referring to. Or is it a generalized seizure? In which case, loss of consciousness during the seizure and involuntary movements, which involve all the four limbs, is typical of a generalized seizure. But generalized actually refers to the loss of consciousness rather than involving all the four limbs. Because sometimes involuntary movements need not be there in some rare type of generalized seizure, like the primary atonic seizure. Is it a focal seizure with a secondary generalization, which you can find out from the description or by observing the seizure while the patient is under observation? Is it a status epilepticus? That means the patient has repeated seizures and there is failure to gain fully conscious state in between seizures. Is it a focal status? That means the focal movement continues without any break in between. Focal seizures occurring in areas other than motor cortex has varying features like visual hallucination, abnormal smells, depending on where is the focus of electrical discharge. So convulsions need not be there in some focal seizures. It may be as emotional upset, abnormal behavior in temporal lobe seizures and limbic system involvement. A focal status involving temporal lobe can look like a psychiatric disorder unless properly evaluated. Unlike a psychiatric problem, the onset will always be abrupt in seizure. And the features of psychiatric illness are absent in such a patient. Psychiatric illness, you will get several other background history to suggest it. Always, if you get a chance or by interviewing the eyewitness, verify whether it is a pseudo seizure. Before proceeding with further evaluation, this has to be verified. Usually, it is easy to differentiate between pseudo seizure and true seizure. But to diagnose pseudo seizure, elicit supportive evidence like conflict in three major areas of human concern, like social, financial, or marital. Conflict may be elicited, and you will get a secondary gain, history of secondary gain from the seizure disorder. Sometimes, when you get an opportunity by interviewing the patient, eyewitness, or by witnessing it, you may get a person with CVA with the coma or post-ictal coma having seizures. That is clear from the history of abrupt onset of neurological deficit and involuntary movements together. This can be happen in embolic strokes and cerebral thrombosis. Because focal signs are uncommon in post-ictal coma. Post-ictal coma has no focal signs. But a space-occupied lesion like AV malformation, cerebral thrombosis, cerebral embolism may present with seizure, and that is where you get a focal deficit and seizure. But after repeated seizures, paralysis can occur. That is called Brod's paralysis. That's when there is a repeated seizure, you may get paralysis of that side. This is very rare phenomenon. Rarely only intracerebral hemorrhage or cerebral infarction develop seizures. This is because most of the typical intracerebral hemorrhages are deep-seated. They are not anywhere in the cortex. That is why, as I mentioned before, it is the embolism that more often presents with seizures. Most often it is cerebral thrombosis with seizures. But intracerebral hemorrhages are not a cause for seizures because the sites of intracerebral hemorrhages are deep-seated. It will not usually irritate the cortex. You need to have a lesion near the cortex to get a seizure disorder. And cerebral infarction can have seizures when the person has a underlying seizure discharge threshold, low threshold area in that region. Paralysis of limb or coma preceding seizure will be a feature of patients who are having CVA with seizures. Fever, if it is present, it has to be elicited, as I mentioned. It could be that febrile illness can suggest a CNS infection, or fever could have precipitated seizure because of high temperature or because of consequent metabolic problems. Fever can be associated with metabolic problems like decreased intake, dehydration, cerebral thrombosis. So there are several reasons why a febrile patient can have seizure, or the fever itself may be due to CNS infection. Diarrhea and vomiting, as I mentioned before, has to be elicited always very carefully. Presence of headache and vomiting and the time relation to seizure can give useful clues. Suppose headache and vomiting was the first thing before seizure, means there is an intracranial problem. But headache and vomiting post-ictally is a post-ictal phenomenon. This time of occurrence of headache and vomiting is important. If headache and vomiting has preceded seizure, it means there is a structural lesion like intracranial space-occupied lesion or chronic meningitis, which is the cause for seizure. Headache and vomiting occurring after seizure may be post-ictal. Weight loss before seizure can suggest underlying chronic infections, uncontrolled diabetes, or endocrine problems like hypothelism or malabsorption, or sometimes malignancy with CNS involvement. Any of these can have metabolic problems which can precipitate seizures. So even seizure does not mean it is, you will not inquire about other problems. Weight loss, fever, everything is important. Sleep deprivation, prolonged fasting, alcohol ingestion has to be asked always. This may cause, this may be the cause for first seizure or a recurrence of seizure in those with the idiopathic seizure disorder. Therefore, avoiding these problems may be the only treatment required in some patients where you can find out these as the precipitating factors. Abstinence from alcohol, avoiding sleep deprivation, avoiding prolonged fasting will reduce seizure frequency in others who are on anticonvulsants also. So alcoholics develop seizures due to, most often, as I mentioned before, due to hypoglycemia, because they are prone for hypoglycemia. These are the causes of seizures in an alcoholic person. It could be hypoglycemia. They always have coexisting hypomagnesemia, hypocalcemia, hyponatremia, pyridoxine deficiency, thiamine deficiency, sleep deprivation, fever, and even intracranial problems can coexist in an alcoholic person. So alcoholics may be having seizure due to multiple reasons. Always be on the lookout for multiple causes. Diabetic patient may be having seizures due to, I always find out is the patient is on OHA or insulin, and what is the compliance status? Has he missed his meals? In that case, it could be hypoglycemia. If he has taken meals and missed insulin and hypoglycemic agent and has symptoms of polyuria, it is hyperglycemia. Had done excessive physical activity more than usual, it could be hypoglycemia. Has there been a dosing error to suggest hypoglycemia, or has he missed the hypoglycemic drugs? In that case, it is hyperglycemia. So we need to find out in a diabetic whether it is hyperglycemia or hypoglycemia, hypoglycemia or hyperglycemia. Was there any acute stressful situation? Has he got symptoms of hypoglycemia? Most importantly, Polyuria may be the only clue to that. Drug therapy for seizures, if he's a non-epileptic, has he missed the dose or changed the drug or received some other drug like rifampicin, which can reduce the drug level of anticonvulsants. Sometimes drug overdosage may be a cause for seizures, like tricyclic antidepressants. Unexplained tiredness before the onset of seizures might indicate endocrine disorders like hypotilism, hypothyroidism also, or sometimes uncontrolled diabetes. The past history has to be elicited very clearly to elicit past history of head injury, past history of CNS infection, diabetes, hypertension, TIA, stroke, and heart disease. Because sometimes the scar of a past CVA may be the cause for a seizure. Abdominal pain, recurrent abdominal pain in young individuals might suggest porphyria or lead poisoning as a cause for seizures. I had a patient who had lead poisoning producing porphyria as a repeated intractable seizures because of contamination of the turmeric powder with lead, I think it was a lead, yellow powder was lead chromate. Muscle cramps, if it is there, might suggest underlying hypocalcemia, hypomagnesemia, or hyponatremia as an underlying cause for seizures. So always ask the patient if the patient is conscious about muscle cramps. Occupation is important to find out history of lead poisoning, or travel outside might indicate it could be an unusual infection with seizures. And coming to physical examination, I complete the rest of the physical examination and all the systems when you get an opportunity. Fundus examination, if it was not done before, a detailed physical examination of a patient with seizure is almost the same as in a comatose patient. So follow the same pattern as you do in a comatose patient. Make sure that it's not a pseudo seizure before we start investigating and treating. Head-to-foot examination or system-wise, correlate each finding with the possible etiologic factor or think of a new possibility that will explain all the findings or most of them. Temperature should be recorded. Sometimes they forget to tell. And if it is high, sometimes they may not give history of fever. But when you examine, there may be fever and think of the same possibilities which we discussed. Pallor, if it is present, consider betel deficiency, folic acid deficiency, chronic kidney disease with uremia may be a cause, or hypertensive encephalopathy may be a cause. Hemolytic states like sickle cell disease can have cerebral infarcts and seizures. Lead poisoning may be a cause for both anemia and seizures. Edema, if it's is there, consider acute nephritis with hypertensive encephalopathy. Always edema raises the possibility of hypertensive encephalopathy or electrolyte imbalance because the patient may be on diuretics which can produce hyponatremia. Always look for dehydration. If there are signs of dehydration, it could be a metabolic cause like diabetic ketoacidosis or a hyperosmolar non-ketotic state or hyponatremia or even uremia because of prerenal factors. Jaundice, if it is present, indicates possibility of hepatic encephalopathy with cerebral edema, which can have seizures due to hypoglycemia and hypocalcemia, or it could be a cerebral malaria or leptospirosis or a hemolytic state, all of which may be associated with the metabolic causes for seizures. So detecting jaundice is very important. If you detect cyanosis, polycythemia due to any cause, including congenital cyanotic heart disease, can have seizures due to hyperviscosity state and consequent cerebral vein thrombosis or cerebral arterial thrombosis or cerebral infarction. Look at the pulse volume. A low volume pulse indicates hypotension due to fluid loss of by any route, which may be associated with the metabolic problems like hyponatremia, hypocalcemia, or hyperviscosity state. Pulse rate, we already mentioned, bradycardia might suggest an intracranial space occupying lesion with raised ICT or even Stokes-Adams attacks. Pulse rhythm, irregular pulse might suggest embolism. Blood pressure, to look for hypertensive encephalopathy. Hypotension and shock raises possibilities like hypotension, Addisonian crisis, septicemia, all should be thought of. Look at the respiratory pattern. Deep rapid breathing suggests metabolic acidosis. It could be sometimes central neurogenic hyperventilation. This can be differentiated by other features. It is very easy to differentiate between metabolic acidosis and central neurogenic hyperventilation. It's not difficult. Hyperventilation producing respiratory alkalosis, as in anxiety or hepatic coma, can trigger hypocalcemia, and that can throw a seizure sometimes. Smell of alcohol Smell of fetal hepaticus or ammoniacal smell can suggest the underlying disorder as the cause of seizure. Smell of alcohol for the alcohol-related seizures, fetal hepaticus for the hepatic encephalopathy related cerebral edema and seizures, ammoniacal smell for the uremia-related seizures. Tachypnea with a clear lung feels may be due to a metabolic acidosis, as in uremia, diabetic ketoacidosis, or it could be central neurogenic hyperventilation. There, obvious neurological deficit will be there. An emaciated appearance can suggest a chronic infection, malignancy, or metabolic disorders like uncontrolled diabetes, or thyrotoxicose or malabsorption. All these kind of seizures due to several mechanisms. Look for a hypothyroid look. A patient may be having the appearance of hypothyroidism. In fact, most of the time, hypothyroidism, frank hypothyroidism is diagnosed by looking at the patient. And they can have seizures due to hyponatremia, because SIADH is very common in patients with hyponatremia. They may come with altered sensorium and seizures. Pallor, jaundice, edema, as I mentioned before, should be looked for. Clubbing might suggest cyanotic heart disease or possibility of CNS involvement by endocarditis. If it is a febrile patient, you can have subacute endocarditis, and clubbing and CNS involvement can be the cause of seizures. Or it may be incidentally occurring chronic liver disease, who can have seizures due to multiple reasons, including cerebral edema. Clubbing can sometimes be due to malignancy, and in that case, you may think of secondaries in the brain. Metabolic problems like hyponatremia may be due to SIADH in malignancies or even in hypothyroidism. Features of chronic kidney disease and chronic liver disease should be looked for. Evidence of neurocutaneous markers of certain disorders of the brain like angiomas, Kaplan spots should be looked for. And always look at the nose and ears for any unusual discharges like pus, blood, or CSF. That might give some intracranial problems. Lymphadenopathy suggests infections or malignancy with the CNS involvement, like lymphoma, leukemias, or they can have metabolic problems like SIDH and hyponatremia too. Clotted tongue can suggest dehydration. In that case, think of hyponatremia, or they may be having cerebral thrombosis. Dry brown coating can suggest uremia. Injury to the tongue in a patient with seizure definitely means, or you don't have to doubt the seizure then. That means it is a true seizure. If you find injury, tongue bite in a patient who is brought with coma, always think that it was a seizure which was developed before the postictal coma. If by chance the patient is comatose in the postictal coma state and the tongue is falling back and obstructing the airway, put the patient in left lateral position, or carefully use an airway if seizures are not unlikely to recur, or if absolutely necessary, also you have to use an airway. But if seizures recur with a displaced oropharyngeal airway, it might produce injury. So that one must be very careful of. Use an oropharyngeal airway if you're sure the seizures are controlled. Otherwise, better delay till the seizures are controlled. Always look for features of hypothyroidism, features of hyperthyroidism. Enlarged and hard thyroid may be suggesting secondaries in the brain. Premature cataract may suggest a hypoparathyroidism. They can have seizures. Or it may be due to diabetes. Chowstack sign should be looked for. Hypocalcemia and coexisting hypomagnesemia could be a sole cause or a precipitating cause of seizure in several patients. CVS look for valvular lesions, dyskinetic apex, because these can suggest embolism as a cause. Respiratory system look for aspiration pneumonia, lung abscess, which can produce seizures due to multiple reasons, or rarely a CF bronchus. Abdomen look for shrunken liver, hepatomegaly to look for a chronic liver disease. So the patient has to be examined thoroughly rather than investigating the seizures alone. Splenomegaly can suggest chronic liver disease, chronic infections, hematological problems like lymphoma, or hemolytic states with seizures. And look for high mental functions like level of sensory and aphasia. Dementia can suggest space-occupying lesion. Dementia in the patient before developing seizure can suggest that. Eyes, look at the pupillary size, reaction, and ocular movements. Conjugate, these are all steps used in evaluating at a comatose patient also. Look for conjugate gaze paralysis, suggest a focal lesion on that side. During seizure, the patient might be looking to the opposite side. Mid-dilated sluggishly reacting pupils can occur soon after a seizure. Don't think that patient, sometimes you may feel that patient is having a coma and non-dilated, dilated, non-reacting pupil you may get immediately after a seizure. don't get upset. It is a normal phenomenon, but it will recover. Unilateral dilatation can suggest a focal lesion with a tendoral herniation. Fundus examination, when possible, has to be done to look for papilledema, fundal hemorrhage, hypertensive changes, or diabetic changes. It can sometimes give some clues to the cause of seizure. Localizing signs like unilateral weakness, one side plantar upgoing, or bilateral plantar upgoing can occur soon after seizure. Soon after seizure, both plantar may be upgoing. So don't think that it's always due to raised nuclear tension, which is going to persist. And like the abnormal pupillary size, upgoing plantar can occur soon after seizure. Look for meningeal signs and examine the skull and spine. Neck stiffness suggests meningitis or subarachnoid hemorrhage, but subarachnoid hemorrhage does not mean it is the usual type of subarachnoid hemorrhage in a patient with seizure. Very often it is turbulent thrombosis with the subarachnoid hemorrhage as a complication. So finally, after evaluation, you must arrive at a clinical judgment, decide whether it is idiopathic seizure or secondary seizure. In either case, identify the precipitating factors. If it is secondary, is it metabolic, vascular, CNS infection, or a space-occupying lesion? Other possible causes by good clinical evaluation. Often the causes are detected by good clinical evaluation alone. You don't need much investigations. Investigations alone without a clinical impression may lead to incorrect conclusions. Remember always that there are multiple precipitating causes in each individual with seizures. This is the most important point to keep in mind. And the success of control depends on identifying all of them and correcting all of them. After arriving at a clinical judgment, only you will be asking for investigation. But you will be taking blood sugar, urea, and electrolytes even at the first instance itself. And elevated urea can suggest uremia, sodium for hyponatremia due to SIADH or hypovolemic states. Calcium magnesium may be done when you suspect it, or if you correct it when you suspect it. So ask for serum calcium phosphorus. When you suspect porphyria, ask for urine porphobilinogen. CT scan head in selected case only. X-ray chest only when you suspect some lung problems. Urine porphobilinogen when you suspect porphyria. ECG when you suspect arrhythmia or ischemia disease or chamber enlargement, which can suggest a source of embolism. Moreover, evidence of complete heart block also you may get from ECG. If you in a patient with undiagnosed seizures, sometimes ECG shows an inferior valve infarction and Stokes-Adams attacks due to complete heart block may be there. CT MRI only when secondary causes are likely. In fact, all patients with seizures do not require CT and MRI. It's not necessary to do CT MRI scans in every patient with seizure. Good clinical evaluation can very often obviate the need for a CT scan. EEG is often a misused investigation in patients with seizures. This is because theoretically you know that a seizure means abnormal excessive electrical discharge in the brain. But if you depend on EEG to diagnose that, you are going to land up in problems, because it is possible to manage most patients with seizures without a single EEG. It is possible to manage. Before the era of CT scan, focal discharge and EEG helped to lateralize the lesion so that people could do a carotid angiogram on that side. That was the kind of indication for EEG those days. Otherwise, previously, people did not do EEG in all patients, only when you wanted to do some procedures. And as for other relevant investigations, there's not much of practical use in day-to-day management for the EEG. Wherever EEG helps in diagnosis, there are typical clinical features like petit mal. Petit mal, definitely you can diagnose by clinical features alone, but EEG has typical features, but you don't need it actually. So therefore, over dependence on EEG leads to improper clinical evaluation and missing the precipitating factors for the seizures. That's why I'm stressing on over dependence is a wrong approach. EEG can be normal in many persons with genuine seizures because the focus of discharge may be deep-seated. You may not get from a surface electrode. So normal EEG does not exclude the seizures. And abnormal EEGs can be seen in many normal individuals. So an EEG cannot always confirm seizures or rule out seizures. That's a point we have to keep in mind. So depending on EEG as a primary investigation to manage seizures is a wrong approach. Use it only as a research tool, not as a routine investigation for all seizures. Most important investigation, I will repeat, good history from an eyewitness and the patient. And CSF study may be useful in some selected cases. Very often meningeal signs are present in such patients. There may not be meningeal sign in some patients with CNS infection. These are patients with encephalitis, meningitis in elderly, septicemia in neonates may not have meningeal signs. Other investigations are done depending on the clinical setting only. So summary of steps in management of seizures means controlling seizure, control of the precipitating factors, maybe in infection, fever, metabolic abnormalities, or cerebral edema, or specific violation, care of the comatose. These are the steps in controlling seizures. So summary of steps in management will be correct all the metabolic abnormalities like hypoglycemia, hyponatremia, hypocalcemia, hypomagnesemia, thiamine deficiency. Not only that, even fetal folic acid deficiency, vitamin D deficiency including. If porphyria is suspected, give diazepam and dextrose infusion, avoid other anticonvulsants. And all the correct precipitating factors, including cerebral edema, has to be controlled because seizure begets seizure. This is primarily because of neuroglycopenia and also because of cerebral edema. So controlling cerebral edema, giving dextrose is important in such patients. And provide care of the comatose if the patient is broad comatose. Maintain on anticonvulsant drug. And these are some of the classical classification of seizures. These are actually for idiopathic seizure disorders. A single seizure that we witness as generalists is usually due to other reasons. But anyway, one must be aware of this classification to properly manage idiopathic seizures. Simple partial means focal seizure. Partial with secondary generalization can occur. As I mentioned before, complex partial refers to the temporal lobe of focus because the patient loses contact with the surroundings, but the abnormal higher mental functions like irrelevant talking abnormally. So that is why it is called complex partial. Actually, it is focus, but the focus is in the temporal lobe. Primary generalized means the tonic-clonic grand mal type of seizure. In petit mal also is a primary generalized seizure. Primary atonic is the patient does not have tonic-clonic movements. The patient just becomes unconscious. This is because maybe the seat of electrical discharge may be in the brainstem. So the patient just loses consciousness. It's extremely rare. Myoclonic seizures are still rare. These are the classifications of seizures. And the anticonvulsants, you all know, the medicine most often used for acute control is phenytoin sodium, but you can use phenobarbital, sodium valproate, or carbamazepine, and newer drugs like lamotrigine or levetiracetam. I will not be discussing on treatment with individual agents. Long-term management of seizures, I need to mention something because the duration of treatment we need to decide. If it is a single seizure and the first episode in life, definite precipitating factor is identified, it may be possible to stop the treatment once the risk factor is avoided. You don't have to continue it lifelong. So if you have a definite risk factor like sleep deprivation, alcohol intake, no persistent seizures, just avoid that risk factor. After the initial control of seizure, you may not have any recurrence. But if the risk persists, or if seizures are likely to recur, or if the patient has a recurrence, continue the anticonvulsant for a minimum period of 3 years. If the patient remains seizure-free for at least 3 years, then only one can attempt at withdrawing the medication. But before withdrawing the medications, all the adjunctive management has to be done. All the preventive measures has to be adopted. On withdrawing, if there is a recurrence, you may have to continue lifelong treatment. Always, these adjunctive measures are very important in management of seizures. The diet should be balanced. Then only they will get to calcium, magnesium, pyridoxine, and other vitamin D and all. So that is one thing which is forgotten. All the essential nutrients in appropriate amounts to avoid deficiency of calcium, magnesium, and pyridoxine. And to prevent hypoglycemia, timely intake of food is important. Prolonged fasting should be avoided. When necessary, vitamin supplements can be given, like B12, folic acid, B vitamins, and vitamin D. Meticulous oral hygiene is important. Daily brushing before going to bed, and if possible, after every meal, will prevent aspiration of infected material into lungs in case of seizure disorder. Not only that, while patient is on phenytoin sodium, gamma hypertrophy occurs in those with poor oral dental hygiene. That's another reason why maintaining oral dental hygiene is very important in seizures. Avoid sleep deprivation, alcohol intake, and smoking, prolonged fasting, and reduce emotional upset by proper stress management. They need psychological support also. to get over the feeling of inferiority complex. These are for the patients with idiopathic seizures arising out of the handicap. They can resort to meditation, exercise, and other relaxation techniques may be useful besides counseling and support from treating. Actually, it is managing physician, not treating physician. And some of the points which I discussed are covered in this book, Doctor's Pocket Companion, which gives the steps to management of seizures.